It's our honor to introduce Dr. Valentin Fuster as our speaker today for Grand Rounds. As you all know, he's a world-renowned cardiologist, scientist, and global health leader whose groundbreaking contributions have transformed the fields of cardiovascular medicine and prevention. We won't go through his whole story to how he got here, but he currently serves as a physician-in-chief of Mount Sinai Hospital and president of the Mount Sinai Fuster Hospital in New York City. He's celebrated for his pioneering research on the mechanisms of atherosclerosis and thrombosis and his advocacy for cardiovascular health across all ages. He's authored thousands of peer-reviewed articles in prestigious journals and is credited for our understanding of some of the most fundamental principles in our practice of cardiology today. And it's important that we review some of his illustrious career highlights. He has at one time been the president of the American Heart Association, president of the World Health Federation, serves as director of the National Center for Cardiovascular Research, the CNIC in Spain, and was the former editor-in-chief of the JACC, the Journal of the American College of Cardiology. And it is impossible to list his every achievement. It's noteworthy that he's the only cardiologist to have received the highest awards for research from the four leading cardiovascular organizations, which are the American Heart Association, the American College of Cardiology, the European Society of Cardiology, and the Inter-American Society of Cardiology. And we're so thankful he's here. Dr. Fuster is deeply committed to bridging the gap between research and public health and is leading the international conversation of health and prevention over the treatment of disease. So this afternoon, we have the privilege of hearing from him as he shares his experience in addressing the paradox of scientific growth without improvement of health. So please join me in welcoming Dr. Valentin Fuster.
Well, thank you very much. It's a pleasure to be here. Actually, I enjoyed the last day or so. Why I say that? Because my wife always asks, it was worth it. And I said, absolutely. This was a few minutes ago. So I'm just giving you a real answer. It was very nice, actually. I enjoyed being with the fellows yesterday and this morning, talking about important issues. The research was presented to me was quite meaningful. And it's a pleasure. So I go back to some of the issues that we addressed yesterday, and that was about a few years ago. I became very concerned that we were more knowledgeable about cardiovascular disease and about cardiovascular health. And as I mentioned, I changed completely my approach to early phases of disease, and particularly what is health in 3 phases of life, using the most sophisticated technology. And this is how we started, and it's the evolving role of technologies as evolved years ago. This is actually, my research goes back to many years, working particularly in arterial disease. The fundamental processes leading to atherosclerotic disease, thrombosis, what happened in the vessel wall. We developed actually MRI to assess the vessel wall and so forth. But as I mentioned about 15 years ago, I really moved from down here to up here, which is how you maintain a healthy vessel. That's the question. And in order to do this, you have to divide the population in different ages because it's quite different, early age, or age 20 to 60, 60 to 100. But this is the most important, I think, aspect that really we got involved is new technology. So we began to address health. What is cardiovascular health with imaging technology? Biology of certain cells that circulate in blood, specifically monocytes. Then new therapies, which is, we have a problem today of adhering patients to medications. And actually it's a long road, but I didn't present this yesterday, not today, but it took us 12 years to develop a polypill that has been approved actually by the WHO as essential medication for people who are not adherent to medications, but not only following myocardial infarction, but even as the European guidelines a few weeks ago is a class 1 on people with just coronary disease. The polypill is not just myocardial infarction and cerebrovascular disease. So the approach has been, and I don't have to go into the details of the polypill, but it's basically we were very worried that people were not taking the medications, and we have proven by the SECURE trial that we published a year ago that following myocardial infarction, a polypill that with a statins, ACE inhibitor, and aspirin, people take it compared with the multiple pills, and we decrease mortality by 31% actually. Even the results were more striking than the results with aspirin in cardiac disease. But this is not what I'm going to be talking about. What I'm talking about is the future of therapeutics, which is the adherence. We have the polypill will go particularly in developing countries, and I think it's going to happen. It's already approved in 30 countries. But what is going to happen, I think, will be subcutaneous therapies. And I can imagine, and I will show you today some of what we are doing, but I imagine hypertension, for example, which is the #1 killer today, being treated with 2 subcutaneous injections a year, affecting angiotensin at the level of the DNA in the liver. This is quite exciting. You see what's happening with amyloid. I will show what is happening with inclisiran in the treatment of high cholesterol with 2 injections a year. So the future, to me, of adherence to medications, which is one of the main challenges that we have, is going to be addressed part by the polypill, but most importantly by addressing the liver with DNA that is responsible of a number of molecules that lead to disease. This is what we are learning by studying health, actually. And finally, whether we like it or not, artificial intelligence is in front of us and is going to be a very important aspect in the cardiovascular field. With some questions we had this morning, some negatives, but I think overall will be a positive. Well, with all of this in mind, we then decided to start with these 2 institutions, the National Center of Cardiovascular Investigation in Madrid. It's an institution of 400 investigators, and actually it's working. But you should know that a number of them have been actually recruited at age 15 and 16 because we give a grant to the school system in Spain, and those who are most curious, not necessarily the highest scores actually, were provided with a grant to spend a month there. And 75% they foster a career. This fosters a career of investigation. They go into medicine, pharmacology, chemistry, biology, and so forth. And I'm so excited about this because it's really discovering people at an age that perhaps they would have never had the opportunity. And this is why I feel so excited. And I was asking, many times in the last 2 days why I'm so crazy to go to Spain once a week. Well, I'm crazy because I'm motivated. It's as simple. I don't think there's any other word. You go there and you see what is happening and you feel part of it, and that's what life makes you going. And this is the medical center at Mount Sinai in New York. So we began all these things I will present to you today in these 2 institutions. And as mentioned yesterday, we began, the first question that presented to us is what is important between age 20 to 60? And what is important is I am developing vascular disease or not. Obviously, it's not clinically manifested, but I would like to see. And classically, we have been talking about risk factors. But obviously, you can be a smoker, but 50% of the smokers never develop a problem, and 50% do. So it's just a statistical game. And the same happens with the other risk factors. So what we decided is to see the disease directly, subclinical disease, which is probably the most important risk factors we know today. I will show it in a moment. And the question is, the coronary arteries are too far from anything, and if you want to see them, you have to inject something. Well, there is calcification, plus minus. But what we decided to do, thinking that the disease is systemic, then whenever we want to approach coronary disease, why we don't begin to approach the large arteries? And maybe the same disease that is developing here is developing the coronaries, which is this no question. We have all the data. So we started by developing 3D ultrasound. And with who? Well, this is the study PESA. There are 3 studies that were done addressing age 20 to 60, 3 studies. The first is PESA, progression of early subclinical atherosclerosis. Basically, we are talking about 4,200 patients, individuals, not patients, with apparently normal cardiovascular system, clinically speaking, 1,500 women that work in a bank in Spain, the Bank of Santander. These are people who were there. Age 40 to 54 years, 55, 54 years. And we follow from 2010 to 2030, every 3 years. And then what we do is we do imaging, as I presented yesterday, and the imaging that we started with 3D ultrasound of both carotid arteries, the aorta and the 2 iliofemoral regions, CT coronary score for coronary arteries, very indirect. And then most exciting today to us is we have begun to do positron emission tomography and MRI of the large arteries, which is something I started when I was in Boston many years ago. Actually, we started MRI at autopsy. That's how the whole field evolved in the vascular system. Anyway, and then we began to use this imaging technology in the body, the 2 carotids, the aorta, iliofemorals, and then with 3D, and then calcification of the coronary arteries. And then we use the same technology to begin to work at the brain about cognitive dysfunction. Here on the right is positron emission tomography. You will see this is what it looks is how the monocytes get into cholesterol, and this is in yellow, trying to take the cholesterol out. And this is the healing phenomena with MRI, and that is, if the cholesterol gets out, this area is converted into a fibrotic lesion with calcification. Calcification means healing, but certainly healing means you had coronary artery disease. That's what the whole calcium score is about. Well, this is very interesting, but what do you do with all of this? Well, we correlate this with lots of factors, cardiometabolic risk factors, more than 4,000. And then multiomics, genomics, transcriptomics, metabolomics, and so forth. This is done every 3 years. So the study is pretty dense and very costly, by the way. The question is, maybe we'll learn something that is not costly. But anyway, that's what research is about. So the study took place, and now this is the first part of age 20 to 60, is the PESA study, which is in people between 40 and age 54. Well, it's interesting, 4,200 individuals, and let me tell you what we learned. First of all, as we mentioned yesterday, the disease begins at age 30 in the iliofemoral region. And you know how we learned this? Actually, by doing a study in children in Harlem, where we also work with the parents. And what we did is we imaged the parents. So we had the opportunity to have young parents, which were age 22 to 35. And then is when we found the disease. In 25% of them was already present at age 30. It's in the iliofemoral region. The disease is not manifested clinically, obviously, because are large arteries. So clinically, to have claudication means a lot. It's a large artery to become very obstructed. Where a coronary artery is very small, you don't need much to be in trouble. But the disease is absolutely the same. I will show you this in a moment. It's a systemic disease. Now, the progression is at 6 years, 33% progress. And this is very important, and I mentioned this yesterday too, that the risk factors that we mention in young people are much more significantly impactful in the development of the disease than later in life. And the risk factors that we began to look at were 8, actually. 2 were physical, blood pressure and obesity. 2 were chemical, glucose and cholesterol. 3 were behavioral, smoking, poor diet, and lack of exercise. And 1 more recently, we studied the 4,000 people, poor sleep. And this is all published, actually, and very interesting. These risk factors have much more impact at age 40 than at age 55 and at age 60. So what I'm really beginning to say is young people, really, let's begin to pay attention to, because we forget about it. We use guidelines at age 50, 60, and we all feel very happy. And actually, we are only in the tip of an iceberg, because everything starts earlier. Then this leads to the guidelines I mentioned. The guidelines are absolutely primitive. It goes into stages with heart attacks, strokes, but doesn't have into account subclinical disease. Actually, it's interesting, Dr. Stone is the first author of the last guidelines on cholesterol. And I called him, and I said, look, I think the guidelines are excellent and so forth, but you guys are in a primitive stage, because you don't take into account subclinical disease. And then the guidelines, there's an article this year in JAC by Stone et al. Saying we should move to earlier age. At least there is already a willingness to move earlier. This is very important. I will show you in a moment about data on this. Microvascular disease, we think about microvascular disease from time to time when we don't know what is going on. I will tell you it starts at an earlier age, and this is something I will show you in a moment. And finally, the acute coronary syndromes, plaque rupture, thrombus formation, vulnerable plaque. This is fine, but today we are beginning to think differently about what it is. I'm going to focus 4, 5, and 6. I don't want to go over this. And all this 10-year, 15-year work actually began to be published, because you have to be very patient, in the last 2 years. And let me start with point 4. This is very fascinating. If you go to guidelines today, the guidelines tell you that an LDL cholesterol of 90 to 120 is normal if there is no cardiovascular disease clinically. Well, you know, in Calgary, subclinical disease by 3D ultrasound in the 4,000 people, look at this. So in fact, in order for you to say the arteries are clean, you need to have an LDL cholesterol of less than 70, less than 60. So that's the first point. But this is not really what was most striking to me. The most striking was diabetes, which is here. We just published this. This is pre-diabetes. Look at the amount of subclinical disease. Tremendous. So to say that pre-diabetes with a hemoglobin A1C of 6.4 is an alarm system for diabetes, I would say to you, it's not an alarm system. You have already subclinical disease that is significant. And I'm sorry for people who might have pre-diabetes here in the room, but the reality is that we have, the way we are talking about is completely primitive. But let me tell you more. Before pre-diabetes, you know there is so-called insulin resistance. Many of you know about it. And that this insulin is there, but it's not working well. You are still not pre-diabetic. We can measure this very easily. Look at this. This is insulin resistance. So we see subclinical disease already before pre-diabetes on people who have insulin resistance. And I could go now into smoking and everything. I'm not going to do this, but this is already published. And it's telling you we are missing the whole game. There are some skeptical people that might tell you subclinical disease doesn't mean anything in terms of events later in life. Well, that's the skeptical people. We'll give you the data in a moment. But this is basically what we found. This is one of the aspects. The interesting is the microcirculation. You know, I became interested in the microcirculation doing the PESA study, the Freedom trial. Diabetic patients with diabetes, diabetic patients with the cabbage versus PCI in diabetes. And we found that certainly cabbage was better in the majority of patients with multivessel disease. But you know, after cabbage, the arteries were open, the veins or saphenous vein grafts were open, but the patients had angina. These were diabetic patients in the Freedom trial. And I became very worried until I became interested in the microcirculation. I said, this is the diabetes affecting something that we don't see with the usual angiography. Well, this led us, in the PESA study, to study 453 people, which actually had some cardiovascular risk factors, and they had subclinical disease. But what we did was actually MRI, and very sophisticated MRI with flow of the microcirculation. And this is what we did in 453 patients. And what we found is significant microvascular disease already in young people. And interestingly, associated in many cases with subclinical disease of the coronary arteries. So it doesn't mean microvascular disease goes alone. You might not have angina, but you already see something in the coronary arteries and so forth. And this is actually some of the data that was just published, in which higher is the degree of systemic disease, like carotids, subclinical disease, iliofemoral, and so forth, higher or lower is the blood flow in the microcirculation with microvascular disease. I have to tell you, this is an issue of great importance, and I don't have time to get into it. But we as clinicians don't care about microvascular disease because we don't know how to measure it. But it's a lot in front of us. In fact, I can tell you very openly, we have the data that today of patients who present to us with coronary artery disease, 25% have significant microvascular disease, 25%. And many times we see normal coronary arteries, we don't pay attention to the microvascular system. Many of these people were women, in a matter of fact, middle age, that had risk factors, and they began to notice something. They were, when originally we studied them, in 2010 they had nothing. In 2000 and later on, 2020, they might develop something, and we found microvascular disease on them. So this is an issue. And I will tell you more. There is a paper published in JACC 3 months ago, 4 months ago, which is a very interesting paper, a stress test in patients, majority women, with normal coronary arteries, by the stress test showing electrocardiographic changes. It's microvascular disease, and we have the proof here. So whenever you do a stress test and the electrocardiogram doesn't look good, the echo may be normal, stress echo, whatever, you do perfusion, but be very careful in calling false positives, because we are beginning to see they are not false positives. This is a reality in its manifestation of microvascular disease. I just want to emphasize that with our knowledge of angiography, we are missing many, many things, which is subclinical disease everywhere. And this is the point I'm trying to make. This comes an issue that to us is absolutely new and very exciting. This began in 2022. We began to do positron emission tomography of the main arteries, the carotids, the aorta, and the iliofemoral. And surprisingly, we saw the bone marrow just lightening up in many of these people, like positive activation. And what we learned, and we know everybody's in agreement, that what we see with PET here is the combination of monocytes that come from the bone marrow, and in this case, substrate is cholesterol. Okay, that's what you see. Well, we began to make these observations in 2022, but things began to evolve slowly, and this is the following. We now have 900 individuals, and we are going to be publishing this very soon, 900 individuals in which we did positron emission tomography and look at the bone marrow and the large arteries. And we see significant disease, actually, in this yellow way. This is fascinating because up until now we had done 3D ultrasound, but we didn't care about the quality of the lesions. Well, you see these, and obviously our interpretation was this is cholesterol, and the monocytes are really there, and this is actually what you are imaging. And interestingly, in some of these people we have followed every 3 years, we have treated them aggressively. This disappears, and let's see what appears, MRI, fibrotic phenomena. So basically, we are showing what the autopsy data showed many years ago, that fatty lesions, you know fatty streaks that you learn in medical school? We are seeing this in the large arteries. And if the risk factors are taken care of and the amount of cholesterol is not very significant, this is converted into a fine fibrotic lesion. And calcium begins to deposit, by the way. When you see a calcium score, it's healing. Well, this is happening. Well, then we developed the concept. The concept is very recent. The publication is old, 2008, but the concept is recent, is that we believe that the deposition of lipid material with risk factor profile, if it is not very significant, the bone marrow is the winner, with the monocytes getting there, taking it out, and with MRI, we see these fibrotic lesions with magnetic resonance imaging. But now comes the key issue. What happens when this amount of yellow material is very significant? These, in general, are people with a high risk factor profile, with lesions in the carotids, in the iliofemorals, and so forth. And we believe this is a problem. Why this is a problem? Because in this situation, the monocytes that get there cannot do the job, and then they decide to commit suicide. This is very well known in biology. In COVID, it was obvious. When the COVID density is high, the monocytes get there and they release cytokines. They are killing themselves. But the killer of a monocyte is very active. It's not passive. They kill themselves, but they release all sorts of substances. Among them, cytokines, metalloproteinases, tissue factor, and so forth. So today, right or wrong, we believe that an acute coronary syndrome is just described as I mentioned now. It's a decompensation in which the defense mechanism is failing with a high risk factor profile and cholesterol deposition. Metalloproteinases are released and leading to plaque rupture, and tissue factor is being released from the apoptotic monocytes, leading to the blood clot. So our concept of acute coronary syndrome has, I wouldn't say has changed drastically, but we begin to understand why there is a plaque rupture, why there is a thrombus formation, and we believe that the defense mechanism is just committing suicide and the whole thing is falling apart. That's what we think. Well, with all of these, also working with the bone marrow, we began to understand risk factors that we didn't understand before. And one of the risk factors I want to mention is CHIP. Well, most of you probably know what is CHIP. CHIP is that a mutation of the cells in the bone marrow that are supposed to defend us. So such monocytes that get into the plaque, if they have mutations, they don't work well. And this is CHIP. Basically mutations of the defense mechanism. And this began to evolve into the hematological field with people who had lymphomas, and they have CHIP that was identified in the bone marrow. Well, we went beyond that, and we began to look at this in the PESA study, actually in the 4,000 people, to identify it. CHIP is easy to measure, by the way, and I will tell you in 2 years, everybody will be measuring, like you measure troponins and all that stuff. I will tell you what it is. You can measure these cells. So what we found, this was just published in Nature Medicine a month ago. What we just found that 20 to 35% of healthy middle-aged individuals, actually there were 3,000 that participated in this study, have CHIP. That is, the defense mechanism is not working. So we now believe that many of the people that we see may be relatively young, actually, no risk factors, and they develop trouble, is a genetic phenomenon, which actually evolves from the bone marrow. It is not working properly. It's the CHIP phenomena. And the question in the literature, the reason why they accepted this paper, will tell you why. It's not only what I'm describing, but there was a this very significant controversy in the literature, and that this CHIP was found associated to atherosclerotic disease. But the controversy was, is the atherosclerotic disease leading to CHIP, an alteration in the bone marrow? Or is CHIP leading to atherosclerotic disease? And the paper is absolutely clear. We follow all these people in PESA. The CHIP begins before the atherosclerotic lesions develop later. And that's why the paper really is an interesting paper, important paper, I believe, because it really tells you that one of the mechanisms is the defense mechanism is affected. And you say, but if the defense mechanism is mutated, this means it's less active. It's not correct. The mutations are overactive. And that's the issue. You know, when you talk about genetics, you know, underplaying or overplaying. A mutation can go both ways. This is CHIP. The system of defense mechanism is so aggressive, and then you have an inflammatory process in the artery that has nothing to do with the defense mechanism, but it's a leading of atherosclerotic disease. When I heard this morning talking about HIV, I was thinking this is an inflammatory process that is not, the defense mechanism is not working. It's the defense mechanism is overworking, and that's what it is. Well, this is basically one aspect. Well, I mentioned to you that in each 20 to 60, we had 3 projects. I just described only one. And that is all these issues of disease starts subclinically at a young age, it progresses rapidly in the young people, then you have genetic phenomena in the bone marrow. But then this was all in PESA, 40 to age 55. But what about between age 20 and 40? Well, many of you may know about the Cardiology study. The Cardiology study was over 1,000 people that in fact began to be looked at age 20 to 40. We are part of it. Well, let's see what happened between age 20 to 40. And this is very interesting. In cigarette smokers, is that right? Pack age, and you say pack month, pack years. This is the way we talk. What it means is you look at the consumption over time. So we did the same in the Cardiology studies. That is over 20 years, 20 to 40. What happened with LDL cholesterol? And you have a graph here. And then what you do at the end is you measure this. Very simple. It's a quantification of the role of LDL over 20 years. We did this with triglycerides, blood pressure, smoking, everything. Okay, and here's the question. What happened 30 to 40 years later? And we have the data. And the question tries to answer is, if there is a problem at young age, this means problems later in life. And the answer is obvious. This is, again, we published this, LDL cholesterol. Higher is the area between age 20 to 40, higher is the cardiovascular events later on, 20 to 40 years later. Triglycerides, blood pressure, we now have diabetes, we have smoking, we have everything. So what we found is that in PESA, the risk factors at young age cause subclinical disease very significantly. But for those who are skeptical, the same risk factors at young age cause events later in life. The only question we didn't answer is the progression of disease that we see in PESA by itself causes the events later in life? Is the only question, I would say. Well, this led to this study, again published just very few weeks ago. Very interesting study, actually. I will tell you interesting because I started this study more than 10 years ago, thinking in the way I am presenting to you. What we did is 3D ultrasound, in this case in people who are older, 55 to 80, because they have events. So you can look at progression if it leads to events for the skeptical people. And I don't have to go into great details, but you know, significant disease at age 55, 13 years later, significant events. And most importantly, progression versus no progression. Progression leads to events. So I presented to you 3 things which lead to the trial that we started a month ago. First, I presented to you that risk factors at young age is bad news and lead to progression of disease very early, more than risk factors later in life. With the cardiac study, I said the risk factors lead to cardiovascular events late in life. The only question left is this progression that we see in PESA leads to cardiovascular events, and this is the bioimage study. And this leads out to the study that we started a month ago in New York. It's the so-called pre-CAT study. 2,000 individuals, young people between age 30 and 49, we consider abnormal and LDL cholesterol more than 70. So now I'm putting together everything I presented. This is abnormal. So these individuals are going to be randomized into what? You already have data. Young people don't take statins. You tell them they stop it. So now we're using inclisiran, 2 subcutaneous injections a year. This is one group, follow-up for 5 years. And the other group is a standard of care according to guidelines. And what we are following is actually progression of disease with 3D ultrasound. But I have to be a little bit more specific. This is the group of patients, the randomization, standard of care versus active treatment, more than 70 milligrams DL because we find subclinical disease. And then the primary endpoint is progression of disease. But what about events? Well, these people are young. So it's a secondary endpoint, but we are not going to see much. But this is actually where the study I presented to you is so important. The progression of disease means events. So the statisticians are all in agreement. If you have a 40-year-old with significant disease, subclinical, and you are treating with inclisiran, you can already see what will happen later in life because of the progression of disease. We have all this data. So what I'm saying is a secondary endpoint, but it's a secondary endpoint that although it will not happen, we will be able to predict based on the data of the bioimage study. This is the study, basically. Inclisiran is given, we treat blood pressure, we treat hemoglobin A1c, so the treatment is very appropriate. Now, we were concerned that the pre-CAT study would be difficult. Young guys, LDLs just more than 70. Who will enter into the study? Okay, in 1 month we enter 50 people already. So there is a sensitivity in the environment that this is important, and particularly when you give subcutaneous injections twice a year, who cares? You understand it? So I think you can see how new therapies are evolving and now getting into young people, which is where the problem is. The disease starts very early, and we have to really move earlier. Well, now the next question is the brain. I'm going too slowly. What is the question in the brain? The question in the brain is cognitive function. And why we don't get there in healthy people and begin to use all the sophisticated technologies that we have. This is very important because the brain, you look at the carotid arteries, the circle of Willis, and geography and so forth, but there's much more than that. There's a microcirculation in the brain, there's cognitive function, there's the parenchyma, so it's a very complicated. So we began to address the brain with 3 studies. Well, this is in Madrid, actually, this first study. This is Dr. Cortez, who is the leader of the study. And I was mentioning yesterday, 50% of my research today is in the brain, so moving from the heart to the brain, because it's the same thing. And I'm going to present 3 studies. The first one was between New York and Madrid, transatlantic TransNIP study, 2018-2021. At that time, the pathologists told us something very interesting, that patients with diabetes, hypertension, or hypercholesterolemia, they had microvascular disease in the brain. This comes just from pathologists. So we said, if this is the case, why we don't use flow in the brain with MRI in people who have these risk factors? And this is basically how we started, with 400 people. These were people with risk factors. They had at least 2 of the 3, diabetes, hypertension, or high cholesterol. And we did MRI flow. This is sophisticated, but we can measure it I don't have the results. This is all published. It was a decrease in flow. Very interesting, because you say, how? We didn't know microvascular disease in the brain was so important, but there is more than that. We found decreased uptake of glucose in the brain when we did positron emission tomography. And this leads to cognitive dysfunction. We are studying this now. This was the first study. The second study was just published in The Lancet, which is some of these people, we follow them. So what I presented to you is flow is decreased, uptake is decreased, but we don't have a follow-up. Look at this. This is 370 of these people. This is the uptake of glucose in the brain. And this is actually 6 years later. In people who have 2 of the 3 risk factors I mentioned, 370 people. There's much more we learn. ApoE4, I don't want to get into this right now. But perhaps important, the same regions that there is a less uptake of glucose is the same regions that Alzheimer's develops. That is in the paper. This is very, very important, because to us, I will tell you in a moment, Alzheimer's disease is very difficult to understand. I can only say to you one historical note. If you read Alzheimer's, who was a pathologist, 100 years ago, said, my disease is a disease of the arterial system. You just read the books. He doesn't mention it's a disease of the parenchyma. What happened is research went into the parenchyma of the brain, because if you have cognitive dysfunction, the last thing you think is about the arteries. This is wrong. This is wrong. Today, if you have angina, you think about the arteries, you don't think about the muscle, because we know a lot about it, but then we didn't know anything about the brain. So the whole thing got into the wrong direction. It's going to the end rather than going to the principle. Well, this is interesting, because the concept we have now, I am summarizing, is that Alzheimer's disease is a very interesting disease, complicated on the parenchyma, but the progression of the disease has a lot to do with the risk factors I mentioned in the arterial system, in the microvascular. The progression, not the beginning of the disease. Well, anyway, this is the second study. But these studies had a problem, and that is not the same patients or the same individuals have all the technologies. The hypothesis was correct. 2 risk factors, the flow with MRI decreases. 2 risk factors, PET scan shows less glucose, but we're not the same individuals. So you are in the hypothesis, but not. So we started the third study in 2022, which is 1,000 people. These are all participants of the PESA study. And actually, we follow them constantly over a period until 2030 with all the technologies that I mentioned to you. And something else, biomarkers here, which is fascinating. This is like troponin in the heart. We have these microfilaments that telling you the brain is beginning to be affected. We have this data in the previous slide, but I didn't want to give you more information. So we are now really very much, with these technologies, much closer. So these are all the technologies in these 1,000 people, and we are going to learn a lot about one issue that to me is now becoming very clear, and that is the same disease that happens in the heart and in the microvascular of the heart is happening in the microvascular of the brain. That up until now, we didn't know how to address it. And now we have technology that is beginning to address. So now I begin to understand that heart attacks take place age 50, age 60, and the generation of the brain takes place later. But probably the fields are different. Is the microvascular in the brain acts later than the large arteries in the heart, which is earlier. The same risk factors. This is very important what I'm telling you, because we see patients that tell us, doctor, you are a pain in the neck. And why? I don't want to lose weight and to stop smoking. My life is going to be miserable. I prefer to die suddenly. That's what they tell you. Well, I said, let's go to the brain, my friend. The brain doesn't go so suddenly like that. You might not recognize your friends, families, and so forth. They change drastically. We don't have any data of follow-up, and we don't have a systematic study. I want to do that study. But they change drastically in front of you. Maybe you're right. I should do this, I should do that. What I'm saying is all of us as cardiologists, let's begin to think about the brain. Because today's society, and you have experience, is more worried about the brain than the heart. The heart is like an old business, but the brain is a new business, and that is cognitive dysfunction, Alzheimer's disease, and so forth. And what I'm telling you is we're dealing with the same, except the timing is different. And Alzheimer's is very peculiar. We have a lot of data on APOE4 and genetics. I don't want to get into that, but just the concept. Well, just to tell you, these studies are very sophisticated. For example, MRI of the brain is not only flow. We are measuring everything, structure, iron deposition, intracranial, obviously, the circle of Willis, all of that. With PET, we are measuring not only uptake of the brain. It's much more. Cognitive tests, we do 8 cognitive testing that are all very standardized. And then we look at the biomarkers in blood. So it's a new science that is evolving very rapidly, and is very exciting. It's at the beginning that is evolving now. But at least I want to be sure that you understand that we are dealing with the same disease. So, all exciting, isn't it? All exciting. And this is what I talked yesterday. It's all exciting, but something is going wrong. That is, despite of all of this, it's a climb of risk factors, more strokes, heart attacks. That's what is happening. And this is what led to talk to you yesterday about the fact of what is being projected in years to come. Blood pressure is increasing, obesity is increasing, diabetes is increasing, and this is the cost and incidence of cardiovascular disease and stroke. And this is actually what happened. And again, this doesn't come out of the blue. This is the American Heart Association just recently, and the NHLBI study showing exactly the same. And here's the question. Obesity is a huge issue. And what is interesting about obesity is that actually it's increasing in adults between age 99 and 214. Doesn't matter we don't have 224. The matter is that actually 75% of the adult obesity starts in childhood, in young people. That's where we have to pay attention to. And that is, we can talk about somebody at age 70 who is obese, try to do the best you can, but the whole thing starts much earlier. And this really led us to what my discussion was yesterday, that really we have to go into kids and education. And this is how we started between birth and age 20. And the concept that I presented to you yesterday is just to finish, is that at young age, under age of 10, the number of receptors in the brain are relatively small, so they listen and they capture, and this comes when you're adults. If you look at yourself today, how you are, you will recognize those first 10 years of your life, the environment that you live, the people that you related to, etc., etc. So the behavior is very important, and that's what led us to begin education at these early ages. Later on, it's much more complex. So, and this is the study we did. I already presented the studies yesterday. I don't want to go into too more detail. But just to finish by saying to you that we are in a very interesting paradox, and that is the evolving of technologies is fascinating. And I think these technologies, in my view, are positive. I don't think are going to prolong life too much more. And we talked about this yesterday, but it's going to improve the quality of life. And that to me is very important. And going earlier, what we are learning with health is we will take care earlier. It's as simple as that. And the quality of life will be better when you are age 70 or 80 or so forth. And the guidelines, I am convinced, that we'll begin to look at things at age 30. I'm absolutely convinced. It will take 2 or 3 years from now. Also, I am convinced that things have to be economic and go to the developing world. I mean, I'm very, 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 I was president of the World Heart Federation, and I visited the whole world. Then I learned that here we are very lucky, because that's not the world. That's the reality. So therefore, if you are working on this business, you become conscious that there is something else. And therefore, I think that these technologies have to be applicable economically. And this is why we developed the polypill, by the way. The origin of the polypill, which I could tell you, but there's no time. It was very interesting. But this is the way it works. And now what we are doing with understanding health is to get earlier and earlier. But what we do in countries where we do not have money, and I began to talk to you yesterday, but basically you had your ultrasound machine that I mentioned yesterday you will be using in a year from now, 2 years, it will be automatized. You will put this here, and your cell phone will tell how much disease is there. It's not going to be complicated. You will not have to be very sophisticated. If you do that, and then you go to the risk factors I mentioned, the 8 risk factors, and then you put the device here in the iliofemoral region, you have everything you need to know, with certainly the disease that you see directly is the highest risk factor. But there is a problem with these countries. This device will be extremely cheap. The problem is taking blood and to measure cholesterol and glucose is too expensive, so we don't take the blood. We assume obesity goes along with high cholesterol, hypertension. You understand it? So in a way, what I'm saying to you, we are already in these countries with the technologies of 3D ultrasound and risk factors, and we take the blood. We don't take any blood, and you can really very rapidly begin to screen populations that they don't have the financial support to have all of this, and that's where we are really moving in this country. So this is why I wanted to give you the impression this morning, I think was in the research, that the 3 issues to me that are important today in terms of health, in cardiovascular health in particular. One is mortality. I think we reach as far as we can. And I told you yesterday, you go to these intensive care units, people are almost dead, but they don't die, But I don't think it will take too long. What I'm saying to you is the issue of mortality is nice to talk, but I don't think it's the main issue today in the cardiovascular. It's quality of life is the issue. That's quite different. Brain function, how you function, lack of angina and so forth. And the third issue is that people have access to everything I'm talking about. And that is, you cannot just talk here in the United States here today and saying, you guys, this is the world of the future. No, this is not the world of the future. In fact, I'm going to Brussels in a couple of days. I have to go, but and there is a symposium entitled "The Future of Cardiology," and my role will be to talk about what I learned in the World Heart Federation of the world that doesn't have what we talk about. This is my job. So what I'm really trying to summarize, and this for the young people particularly, is that the mortality issues, you can read, preserved ejection fraction a little bit better with SGLT2 in here. You're not going to change a lot, the mortality. I think what the quality of life will be if we go earlier in life and if we use education in childhood. And that to me is critical. And then be sure that you are conscious of the fact that the world, 2/3 of the world is not the world that we live here today. And so we have to be very conscious of that. So all these developments need to be affordable, or people have the access. Well, look, it was nice to be with you in the last couple of days, and at least I expressed to you what I think, but I hope at least is some way to think of all these aspects, and that's what is good to have all these relations and discussions. Thank you.
We have time for maybe 1 or 2 questions.
I have a question.
Okay, yes.
I'm heart failure. Heart primordial artery prevention, but my question is, since we're talking about primordial prevention, what are your thoughts on our considerations on germline traumatic cell engineering based on the risk profiles of patients?
I don't have any idea at this point.
I mean,
It's hard. I think it's interesting, and we have to look forward. But, you know, well, first of all, this is a very complex subject because, for example, when we talk about primordial prevention, I think has to start with the mother, even before. And now, I didn't present this today. We are going even before pregnancy in people. What I'm saying to you is we have to advance very much into what is at hand, and then there are new approaches that could be of interest. That's all what I can tell you. But I cannot answer your question, though.
All right, I'll ask one question. So I was struck when you presented that 25 to 30% mutation rate in the chip mutations. I mean, it seems almost beyond nature. I mean, how does that evolve? I mean, how's that? I mean, is there any concept of why that happens?
We have a process of degeneration with age. And I think these mutations are part of the degenerative process. And the question I'm really presenting here is when we talk about genetics, we have to be very conscious that we know hypercholesterolemia, we know about many things, but there are things that are beyond that are beginning to evolve. And this is one of them. And I think basically, it's 25 to 30% of the adult population between age 40 and 55. Yeah.
That's incredible.
Yeah. Can I follow up on that? Oh, sorry. Deputy, go ahead.
No, I was, obviously you keep opening our eyes. It has my whole career. I've been following your work, and it's amazing. But looking at your work with the brain, which I think is fascinating, I was just wondering if you, the new data with the GLP-1s and inflammation and amyloid deposition maybe, and cognitive dysfunction improvement. What are your thoughts on that?
Well, first of all, the data is not very striking, but at least it's data that is positive for the treatment of Alzheimer's disease, at least. The question is where we go from here, and in terms of amyloid, I think the field will advance significantly when we learn how to address amyloid, which we are already in the heart, but not so much in the brain. And I think I feel relatively optimistic about it. But one of the things I want to emphasize to you, however, is that we have to go much earlier on everything we do. And in Alzheimer's disease particularly, when it can be identified 10 years before one is clinically has the disease, we have to approach that. And this is beginning to evolve with ApoE4, for example, and with other aspects. Is quite fascinating. And the question is we have to go much earlier. But one point that I want to emphasize in my discussion today is the progression of Alzheimer's we see a lot has to do with the factors I am mentioning. These factors that affect, but not the disease in itself.
Okay,
I think he had some question, no?
Whatever you need. I was going to follow up on yours, because I agree. I think that 25% chip mutation rate is very elevated. And do you think that it's part and parcel with cardiometabolic dysfunction, with dyslipidemia, rather than necessarily blood pressure,
it's very
promoting cellular dysfunction? And then
well, it's very interesting what you say. In fact, we just published the data. The metabolic syndrome promotes those mutations.
Right, which is pervasive.
Obesity and so forth. And I didn't want to say too much because it's all so early stages. But it seems to me there is a lot of the risk factors that we thought affect the endothelium. Right. And then as the disease develops, there are two issues that are evolving very rapidly. One is the effect in the bone marrow of affecting all these defense mechanisms. And the other is the perivascular fat, which people didn't pay attention. It's like the fat in the epicardium with the muscle of the heart. Well, the fat outside the artery appears to be also interesting in the pathogen. All these things are evolving, but you are quite right. The metabolic syndrome may have implications in CHIP.
For sure, and insulin levels.
Yeah, insulin levels too.
Okay, I'd like to thank Dr. Fuster for joining us. It was hard to get him here, but I hope it was certainly a wonderful visit for us, and I hope it was a wonderful visit for you. Really, on behalf of the cardiovascular division, you want to come here?
Okay, good.
We have. I'd like to present to you a plaque honoring you as a pioneer in cardiovascular disease, and we'll get the picture.
Thank you very
We
much.
really appreciate your time and your knowledge and
Pleasure.
and sharing it with us. It was really a pleasure to have you here.
And good luck to the young people. All of you are young. Thank you.